I'm Krista, and I am a labor and delivery nurse and postpartum nurse and medical surgical pediatric nurse at Winona Health. I have been working there now for 10 years within the labor and delivery. I really enjoy my job. I also teach, and I'm super passionate about, like, my jam is, I'm an instructor for neonatal resuscitation. And so that's the part within the first couple of hours after delivery, resuscitating a baby if it's not breathing, and stable certified, how to keep a baby stable until we get it to a NICU. At Winona Health, we don't have a NICU, and we don't try to purposely deliver babies who are less than 35 weeks gestation, but of course they show up and we deliver them. And so babies, women delivering, that's one of my favorite things to do, but it's not the only thing I do. I do want to preface, and I would probably say this a lot, I'm not a doctor. I did not go to medical school. I do not have been professionally trained to deliver babies. What I have been trained to do is how to deliver a baby if it's coming out really quickly, and I don't have a doctor. At Winona Health, we don't have doctors sleeping in-house 24/7. They just have to be within the remote area. So unfortunately, I have had to deliver a couple of babies by myself. It's really fun, but it's not like I don't look forward to that. Just like you guys don't. Like, we don't want to do that, right? We want the people who went to school and are getting paid to make those decisions, that person. But babies come when they want to come, whether you have a doctor there or not. After Courtney explains who she is, and yes, she's she's not me. She is my identical twin sister. We actually do work together, so this is kind of perfect.
But yeah, I've been at Winona Health for a little over 4 years now. I work in our simulation lab, so I run these. We have 5 of these high fidelity mannequins, from a baby all the way up to a geriatric patient. We have a birthing mother, just a general adult, and then like a toddler mannequin.
I'm happy we're gonna go through some deliveries, some things to watch for, like warning signs type things like that. Delivery of baby, we'll go through some resuscitation, and then some like post-delivery complications that can happen. But I really wanna hammer home that if a baby is delivering precipitously, really fast, out in the wild, odds are that baby will be just fine. They come when they can come super preterm, and we can, there's complications that can happen like that, but most babies, like the situation that you have, are gonna come out and they're gonna be completely fine, and you can be completely hands-off. You don't have to be maneuvering or manipulating much in that situation. Like, most times that is gonna be the case. And then the rest, like baby, I'll tell you some really helpful tips, tricks, things like that after baby's born. And then, if mom's the main complication, number one, complication after delivery is hemorrhage. I'll talk through some things if the mom starts to bleed more than you were liking. But truly keep it really high level. And my goal at the end of today would be to instill that all women, it gets scary, it hurts, and there's pain, and they're not in their situation that they thought they would be, right? We all expect and anticipate the kind of birth that we have in our mind. And when it doesn't go that way, then it instills fear. Even in a hospital situation, we run into that all the time, right? A woman thinks she's gonna deliver with no epidural and vaginally, and then here we are in a C-section, she's got all the meds. And that they're scared, even though they're in a controlled environment. So the main goal I can instill after today is just, if you can make your mom feel safe, she will have such a better outcome. Sure, there still might be complications, but like, if you can get eye level with that mom, and just reassure her that, like, hey, you're okay, we're gonna take great care of you. I've done this before, or so-and-so Shannon did it last time. That's truly what's gonna make that mom be able to like listen to the words that are coming in. If you go in there and you're frantic and you're panicking yourself, nothing you say is gonna go into that mom. Even in the hospital situation, like if I don't build really good, quick rapport with the moms who come in off the street and deliver a baby in the elevator, trauma that they have from that, like they have a lot less trauma and a lot less of the, it seems they have a better experience if you can just make them feel safe, which I know all of you are capable of doing. And a lot of that is just, like I said, like with your words. Of course, there's skill that goes into this, but truly most babies that you deliver are not gonna need all of that skill, fancy stuff. They just need to be warm, dried, stimulated, most of them. Okay? Okay, so we'll kind of start up at the box number 1. So if delivery is imminent, or like we say, like precipitous or happening before you can ever get to a doctor, delivery is imminent when you see these signs. So crowning, does everyone know what crowning is? Yep. Sometimes people will say, oh, baby's crowning, and you're looking at their vulva. Like right now, is she crowning?
Sorry, Paul.
It seems, oh, even though mom's screaming and the baby's coming out, ah! She's getting much closer to crowning, yep. But either way, you don't have to know when crowning is happening, because crowning, she can go from you can't see that head at all to now boom, the head is already out. Crowning would be, again, if you can see the head, exactly like you said. And then it just will continue to come out, which you don't have to go too far into that. If you start to see the baby's head or you start to see hair, I don't have to have my hands on this mom. More times than not, she's actually not going to want you to touch her. She's going to be like, get away. If you have to or want to, you can just apply a little bit of counter pressure just to her lower, like here, vulva area. But again, you don't have to. If that baby's coming, it's coming whether your hand there is not. And I'm not holding the baby in. I'm just supporting her perineum so I don't have a massive tear. Babies who come out really fast don't stretch things appropriately like they need to, and that's when you're gonna get the tear. So I'm just controlling the delivery of that head by just holding a slight amount of counter pressure. But again, if you don't want to touch her, she probably doesn't want you to touch her. You don't have to do that. Another way you might know baby's coming imminently is like, I'm gonna poop, I'm gonna have a bowel movement. I've had women say like, I'm pooping right now. I'm like, no, you're not. Or if you are, I don't care. It's the baby, it's literally the head coming down. So if they say that, that would be a reason for me. If she had her pants on, or it was all covered up and she's like, oh, I feel like I'm having a bowel movement, I would want her pants off. For sure, if that to me would be, things are moving a little quicker. And then contractions, less than or about 2 minutes apart. Again, you don't have to time contractions. She's going to tell you with her voice when she's contracting. Some women though can be in Braxton Hicks and have contractions every 2 minutes for weeks. So, we of course have our frequent flyers that we see on a very regular basis, starting at like 20 weeks. And they'll come in via ambulance and just screaming, my contractions are 2 minutes apart. Okay, but what else? So that wouldn't be the only thing that would make me think that that woman's having a baby precipitously. But if it's her like 3rd, 4th, 5th baby and they're every 2 minutes apart and she says a couple of these other things, then I'm like, oh yeah, that baby's coming. She knows. Okay? And then that multi-pair, that just means someone who's had more than one baby. Doesn't mean they've had 5 or more, but just more than one. And then a bulging perineum. So like crowning, you can't quite see the head. But if you would take down her pants, you would see like everything just looks really full, really swollen, really puffy. If she has like a bulging perineum, now I'm telling myself like, I might hold some counter pressure. If she's in a car, you're not going to be able to hold counter pressure really easily. But if she's in the back on your stretcher, then you might be able to. Also, not everyone delivers their baby on their back with their legs up. That's actually not the recommended way. Some women prefer to do it that way, but if she wants to be on all fours, if she wants to be sitting on the side, kind of just let her. Like her body knows what to do. Every second person in America, body is built to have babies. Yes, some are better at it than others, but just keep reminding her, her body knows what it's doing. Listen to her body, right? When she's losing it, hey, you got this. Listen to your body. If your body's telling you to push, we're gonna breathe through that push. focus on, I like try to, if I don't want my patient to push because I don't have a doctor there yet, I can tell her not to push, her body's just gonna push for her. But if I can get her mind focused on something else, hey, let's focus on wiggle your toes. Focus on your toes, and we're gonna ride the wave. Like I've got all my back pocket sayings. We're gonna breathe through this contraction, and if she starts to bear down, hey, take a breath. Breathe through that contraction. Hey, now we just got through one more contraction. Look, we're so much closer to the hospital if you weren't stopped on the side of the road or whatnot. And just like keep educating while she's going through that. That can slow down the process, but it won't prevent it from happening. Like I said, her body will just take over and do that, and that's okay too. She might say, shut up, I'm gonna push, or I'm not trying to push, but I'm pushing. Go right around, okay, sounds good. Then again, I'm right here with you. I'm gonna take care of your baby. You're gonna be safe. Everything's gonna be safe, right? We're gonna keep reaffirming that safetyness. Here's just like some suggested equipment, which is what you guys basically already have in your OB kits. But there's like a maternal list, and so gloves, obviously, gowns, face shield I think is a little excessive. We don't wear them in the hospital. Some doctors I guess might, but you can if you want to. If I knew this, if my patient had like HIV or something, I might try to be extra protective, but I think a face shield's a little above and beyond. And then absorbent pads or towels, anything that you have. As you know, delivering your baby is a very messy process. Lots of fluids, probably lots of blood. So if you have any of those extra things to absorb some of that, great. If you don't, that's okay. You don't absolutely need them. Sterile drape, again, if possible. In the hospital setting, we like to pretend that a delivery is a sterile procedure process. It's really not. Yes, it's coming out of a sac of fluid that had been sterile, but like it's not a sterile process. So you don't have to have that sterile thing, sterile gloves, sterile drape, any of that. Suction, it only mentions suction that if your mom had been preeclamptic or eclamptic and starts to have a seizure, you're gonna want to just suction just like you would for any other suction or person who is seizing and potentially vomiting. That's the only reason for suction. We're not suctioning the baby out. We're not applying a vacuum. We're not doing any of that out in the field. And then IV supplies. If you could put in an IV before you ever got to the hospital, or if there was time to do that, absolutely do that. But I would not delay transport to get an IV. I mean, women had delivered babies for years without IVs. So that would be like if I had time, but we were already moving, or if she had told me, hey, I hemorrhaged with my last couple of babies, like a lot, I'd probably want to move to an IV a little bit quicker and start. You guys have saline and all, like I'd want to maybe just like bolus or a bag if I had time. But again, I'm getting to the hospital and like they've got meds that they can give, and we'll just do it there. Okay, then the newborn supply list. So your neonatal bag mask, which we found, but your neonatal sized one, the risk of, if you start using a peds one, if you open it, wouldn't be the worst thing in the world, but you could you could give that baby a pneumo and collapse them if you inflated too much into them. So this one's nice, and still even this one, you're not gonna completely compress. You're gonna do about a half to a third for a breath. Okay, so trying to grab your smallest one, but again, most babies you deliver will not need you to do this, but I'm gonna talk through how if we have to. So there's your bag mask valve, or device. Neonatal mask, which Shannon showed me. You guys have the size 1, which is great, and it would fit. It does fit. I would even maybe get a size 2 because that's even getting a little small. So you can make it work even with a size 3. So there's a size between these that would just be like ideal for a newborn. Most newborns, you could go with the bigger size if this wasn't making a good seal over the mouth and nose, and you were having a lot of air leak and you couldn't get a good seal. You could use the bigger to get a better seal too. It's okay. That would just be like perfect world if you could order the 2. But make do with what you have. Warm blankets. So again, most babies just need to be warm and dried and stimulated. So do you have a blanket warmer?
No.
Or, oh, that's okay. Or a stack of,
We can crank the heat up.
yeah,
a bit.
that would be perfect if you can think ahead to do that. And then just even if they're not even warm blankets, just have a lot of blankets or a hat, somebody's hat, any sort of dry material, towel, anything that you have. Sometimes dad's t-shirt or a dad's sweatshirt if you can't find one, like he'll gladly, I'm sure, take that off so you can dry his baby. That works too. And then a hat, which I know was I saw one of them. Babies lose a lot of their heat out of the top of their head. So as quick as you can get a hat on and then dry the rest of their body, the better. Babies, if they're not thermal regulated rather quickly after, it is just a chain effect of everything else that's gonna go wrong. They'll drop their blood sugars really quickly, which then again affects their respiratory rate, which affects their heart rate, which we're trying to keep above a certain number. So just like heat and dry and warm stimulation is really gonna help your baby keep all of those vital signs within a normal parameter. If that heat is off, truly the rest of them all just start to tank too, okay? A pulse ox, I said, if available, I wouldn't put it on. Of course, in a hospital setting, we pop it on a lot of babies. But I think if you would pop one on, babies don't have to be at 100% oxygen, and they won't be at that until about at least 10 minutes of life. Most of them will sit at they can sit at 65% O2 for like 3 minutes, and that's normal, that's okay. So I wouldn't want you to put on a pulse ox and then think you have to treat that with like some supplemental O2, because you don't. If you think of like the physiology of where they just came from a swimming pool that they were living under, so their lungs are full of fluid. And so they're not going to have 100% O2 straight out. They're trying to push that fluid out of their lung space. And so filling those and popping open those areolas with air, but that takes time. So we give babies like 10 minutes to try to get their sats up to 100% by themselves, or with a little bit of CPAP. And then cord clamps, ideally 2, which this one has, I saw them on here, 2 cord clamps. And then I saw somewhere, did you have extra cord clamps I saw in there? No? Oh, it was in that, your training kit. Clamps to clamp the cord, if you can remember and if there's time. We'll talk through that when we go delivering the placenta and things too. And scissors, and then a bulb syringe. And it says, if protocol allows, your kit does have a bulb suction in here. That's awesome. You absolutely, it used to be standard protocol that every single baby who was born got the bulb suction. You would do the mouth first and then the nose. Now per NRP or neonatal resuscitation, they say you can use bulb suction, but you don't have to. Really just as effective as the bulb suction is just taking, I don't want to unplug it. If you take a blanket or any sort of material, and if you wipe their mouth and their nose, just as effective as a bulb suction. Yep, so if your baby is crying, don't shove a bulb suction in its mouth just because you've seen that's what people do. You can also, if you push that bulb suction too far back into the back of their throat, you can cause a vasovagal maneuver, and then they're holding their breath and they're not breathing, and then all your vitals are going down, and it can cause soft tissue trauma at the back of their throat too. So really the only indications that you would want to use your bulb suction is if, let's say, that baby came out and had maybe meconium, or when they poop before they come out, that can be really thick and green and sludgy. If you saw that they had like meconium all over their face, or even through the birth canal, if mom tears really bad, sometimes their whole face can be covered with blood, and that can clot at the back of their throat. So if you can visually see that they have a bunch of gunk like in the back of their mouth or clogging up their nose, then you might want to use your bulb suction. But you really, truly, most of what you need to do is just with a towel and wiping out their mouth and their nose. Throw the bulb suction away after you use it a couple of times. You can't really clean those, so they're just gross. So I won't open it because I don't think we need to do that. But that bulb suction is that little blue thing. You guys know what a bulb suction is. And then it comes with a drape, which again, I wouldn't mess around throwing up a drape. That's just gonna waste time. But you can if you want to. If anything, I would take that drape and I'd put it on the ground or the floor to just scoop up my mess when I was done. And you have an emergency blanket or silver swaddler, it's called. It's probably something very similar to this, which is great, and keep that nice and dry and warm after the baby's born, that you can use it. It comes again with an isolation gown. If you want to throw in a gown, you do that. If there's time to do that, I think there's time to get like moving. There's some maxi pads with wings. I like how it specifies. If you, after delivery, if mom wants to be covered up, sure, you could throw that in her underwear, but most likely just leave her underwear off. The hospital's gonna want her naked when you get there anyway, to assess for any tears in placenta and things like that. There's a plastic placenta bag. That's super nice. If you have to deliver the placenta in the field, you can truly put it in any plastic container too. The hospital will take it in anything, or if you can't find that, just wrap it up in a towel or something. We'll take that too. If the baby had a lot of complications after delivery, we would actually want to send that placenta to pathology. So it is good to, if you have to deliver the placenta, to try and bring it with the patient. Scissors, an umbilical cord for the umbilical cord to cut it. A nice trash bag. There's gloves in here. Alcohol prep pads. I don't think you need to use those for anything. There is a disposable pair of mesh underwear. There's an OB towelette, which again, I would use all the towels that you have to dry and stimulate that baby. Mom, we can just clean up with any old towel or whatever you have, but anything clean and dry and warm, use that for the baby. Plastic pre-cut twist ties. Funny story, I have had a mom come in, and she delivered her baby, and she tied off her placenta with dental floss. So she got pretty creative. So I was like, the cord, would you use twist ties for? That could work. I don't know what those are for. 2 cord clamps, and then umbilical tape, which in my world, umbilical tape is literally just this really small piece of string. I don't know what you're gonna need to use that for. Because if you already clamp 2 spots and cut in the middle, you don't need to clamp anything else. And then 4 towels and some gauze sponges, 6 gauze sponges, 4x4s. I'll be super hesitant to use those anywhere either, especially on mom. If she were bleeding a lot, I would not use a 4x4. Those could get lost. If you use them, I would just use a towel. If you were gonna like hold a tear that you could see, I would just hold pressure with something bigger than something that could get lost up inside of her. But they're there. You could use the 4x4s, I guess, to wipe the mouth and the nose if you needed to too. And then again, medications. Shannon had told me that you guys don't have any meds other than like some code blue meds, right, you give for ACLS, but nothing else. Most moms delivering shouldn't need anything. That's okay. And if they do, that can get done at the hospital. I work really closely with the ambulance director for WAS. And he reiterated when we were talking today, he was like, please tell them that if this ever happens and you're transporting, that they would come intercept and meet you halfway or more than halfway if you hear of something, like they want to. And I do a lot of their trainings too, and I know that they have hemorrhage meds in their rig. So like if you haven't, like get them to her, they can give their oxytocin and they can give, they've got a couple other meds too that they can give. So please, he was like, don't tell them to hesitate. Don't hesitate to call them. They want to come pick up and like intercept and meet you guys. So that baby's not breathing yet. It's still getting mom's circulation. It's not breathing any oxygen, like it's getting oxygen delivered through that umbilical cord and the placenta. So blue is actually a super normal color. If it turned to black or something and it was being super restricted, that's bad. But like blue is actually pretty normal. All babies come out a little blue or like disgusting purple until they take those first couple breaths and then they pink up. So super common, and a lot of people will say, oh my gosh, my baby came out blue and it was terrible. It's like, well, that's normal. But I get it, still super traumatic if they had extra complications and stuff. But yeah, I would just, yeah, poor thing. And now you have a foot hanging out of your vagina. Yeah. So then on to step 3. So just steps, again, uncomplicated delivery, and that's just the main thing I wanted to talk about today. We can absolutely talk through complicated-ish deliveries. I'm not a doctor, but we'll talk through them. So as the head delivers, support that head gently if the mom wants you to and if you can reach it. But again, you don't have to do that. You do not have to get hands-on. And by doing that, you're just gonna hold a small hand right under here. And again, I'm not holding that baby in, and I'm not praying that it, well, maybe I'm praying that it just stays in, but I'm not pushing it back in and I'm not causing any trauma that way. I'm just holding pressure to her perineum. And then check for that nuchal cord. So actually super common, like every other baby comes with at least one nuchal cord or cord wrapped around its neck at least once. And so as that head, this one doesn't have a cord, but that one does. Can you do that one? No, you can leave it in. I'll just push it out. Okay, so after the head is delivered, that's when you check once for a cord, and you literally just run your hands around the side of the head, and you'll either see it or feel it. Babies should also come out looking at the floor. If they don't, that's just a different position. It's fine. If they come out looking any other way, that's okay too. Doesn't mean there's anything necessarily absolutely wrong. She just might have to push a little harder for the shoulders. So if the head is out, you can run your fingers kind of just along the side, and if you can see and feel that cord, you're just gonna gently, and if it lets you, you're just gonna gently pull it over. And this is real, it's not truly that hard. You're just gonna gently pull it over.
Is it quite stretchy?
Yeah, yep. I have only seen in 10 years one that they couldn't pull over, and we had to clamp at the perineum and cut because baby couldn't deliver through, but that was wrapped around like 4 times. Really, really tight, so we had to clamp and cut at the perineum, but really that was one time in 10 years. So it's pretty stretchy, they're pretty forgiving, but if you are really tugging, then it's fine. She can deliver through it, that's okay. But if you can, you're just gonna move that. But again, odds are mom is moving so fast that you're not even gonna have time to even check for a cord. But if you can see it, cool, just let her know, I'm just looking for a cord. Oh, yep, I'm just gonna remove that from around his neck, and I'm staying super calm. Yeah.
How do you know which way to go?
You'll kind of be able to tell, and it's hard to explain until we have like a real one. Like if you had tried to go this way, like there's gonna be less give. Yep, and usually more times than not, it's right up here and you just go straight down over the head. And I put it on really tight, okay? But you'll know, like, and if you drew it up here and it's not giving it all, then you can go down under here and you can try to come up that way. And if it's wrapped again, you twist and pull it over again. You might get one done and then the shoulder might pop out. So you don't have to, like, that baby, again, isn't gonna wait for you to do that most times. So if she can just deliver through that, that's fine. Even if she delivers through that and then the cord ruptures as she's delivering through that, that's okay. You're just gonna grab both sides of the cord that's bleeding and clamp them. That's okay. And then we just take care of baby and we move on. So after we check for the cord and if we had to reduce that, we did. Then that anterior shoulder, as babies kind of like mal-rotate, they start kind of looking at the floor, then they turn one way or the other. Whatever shoulder, this anterior shoulder is gonna be the shoulder that comes out first. So you'll kind of see them come under the pubic bone and that top shoulder is gonna pop out. So as they kind of mal-rotate, maybe I'll bend down, is that better? Can you see? I don't know how to. As that baby, if you can, as that head comes out, now is when I would have my gloves on. I'd be like, hey, I'm just down here making sure that baby doesn't fall on the ground or whatnot. I'm just holding gently. And I like to kind of like hold their little cheeks and by their ears. And I might do just the slightest bit of downward to get that anterior shoulder to pop through the pubic bone. As soon as that anterior shoulder pops through, then I'm just slowly lifting up a little bit until that posterior shoulder comes out. Okay? And easy as that. if you don't make it there with your hands, or you can only reach one hand down there or no hands, she will deliver that baby. It's gonna be okay.
Oh, don't do that.
They're slippery.
Yeah. We all hear the stories of how flexible babies are.
Yeah.
And how they truly are superhuman.
And resilient, yeah.
Yes, yes. So explain that a little bit. You've got, I mean, if baby's upside down and, starting to see this, the neck is going back. And it feels
Like positioned wise, like looking up instead of down? Yeah.
Exactly. And maybe in a weird case scenario, you're seeing that flexation, or that flexing, tell us a little bit like the best case for us.
Baby's up here.
Yeah, looking up. So again, if it comes out, I've seen like even just their face is the first thing that comes out.
Wow.
It's fine.
Yep.
Mom's probably gonna push a little bit harder, but again, if that baby is coming and you can't, it's still gonna be okay, and it's probably still just gonna literally pop right out of there before you even have time to. But if baby starts to come this way, regardless if they're looking straight up, they still will do that malrotation. So they're still gonna try to turn one way or the other. If they don't or whatnot, and you're holding his little cheeks, you'll be able to tell which shoulder is probably up a little bit more than the other one, just by the way that their head is starting to look. I'm still, regardless if they were looking up, I'm still gonna do a little bit of downward till that anterior shoulder pops, and then I'm just gonna come up. It's a boy. If it is a hand or a foot or 2 feet or a butt, we're just saying, Mom, don't push. And even if she is pushing, we are just hightailing it to the hospital. I have not been trained to deliver. Most OBs aren't even comfortable, competent delivering a breech baby. That's why we go straight to the OR, unless she was already delivering it. The head is the hardest part of the baby to deliver. After you deliver the head, the body seems to follow pretty easily after that. So if they're breech and baby came out foot first, butt first, and the hardest part, and you come in and the head, or the whole body is out, the hardest part for mom will be the head. And now this is a true emergency. She needs to deliver. Once the most of the baby is delivered, that dry or that cold air stimulates baby to try to start breathing. And so now we're, and then where's our cord too? Our cord is probably still in the birth canal and getting clamped off. So we really need mom to deliver that head. So we're just gonna tell her to push with all of her might, and she just needs to push really, really hard. If you're not successful with whatever way she is, literally try every position. Try side lying, try both side lying, flip flop both sides, try your hands and knees, try standing, try squatting. I would literally do anything I could then to get that baby delivered. But I would not pull. I'm not pulling on the head. But I'm gonna give her a little bit of help, gentle traction to try to get that baby to come out. But I would be holding the body, and as she pushes, trying to get that baby to come out. But just reminding her, hey, a lot of the body's out. I really need you to push as hard as you can now. The head is what's hanging us up. We really need to get the head delivered. And drive really fast to the hospital. They can flip the night before, especially moms who've had more than one baby. Most babies don't engage into the pelvis until you are in active labor. So they're just floating up in la la land, even if you're a couple centimeters dilated. And so they really have they can flip around and they can do all stupid things, even in labor. First time moms though, those babies drop into the pelvis rather quickly. But again, weirder things have happened where they can flip anytime. If the baby is engaged in the pelvis, they're not flipping, once they're down there. Okay, what other questions on that part?
Roughly how long is the
Oh, all different. The longest one I've seen has been 200 centimeters. It was so long. The shortest one I've seen is probably God, I don't know how long that is. Probably that long? 40? Yeah, all very different. Yeah, nope, and you won't know that. You won't know that. Most people won't know that until after the baby's born. The cords too, some are super, super thick. It's all dependent on the mothers. Yeah, I've seen really thick ones, and some are just super scrawny. The smokers usually have really scrawny little cords, which is fine. Again, that's not gonna stop anything that you're doing. But yeah, just don't be shocked. And they're really bright blue. the vessels in it. So sometimes if the cord is around the neck, you'll be like, oh my God, what is that? It's truly the cord, and it's just like those big bulging vessels. But yeah, the Wharton's jelly and whatnot can be really thick. That's a really well-nourished baby. So the anterior shoulder delivers first. Like I said, you'll pour the gentle support only, never apply traction or twisting. So after the baby delivers then, again, dry immediately, place skin to skin. The best place for a baby is skin to skin. So if you can take mom's bra off, or if you can't, with everything going on, lift up her shirt, get baby under her shirt so you can still see its mouth and nose, but at the most skin to skin contact, the better. That really helps baby's thermal regulation. That helps with breastfeeding down the road, which I know you don't care about right now, but it truly, baby's heart rate and respiratory rate will regulate if they're skin to skin with mom. It is weird, but it really works. And then cover with warm blankets, like I said, which you guys already did. Like the more, again, warm, get those blankets on. And if you just can see a little peep of that baby's mouth and nose and get a stethoscope in to listen, that's all you need. The rest of this baby should be covered. There shouldn't be a part of it that's just out and naked, open to the air. That will cause way more problems for you. And then apply a hat or Nate's hat, whatever you have. Okay. Now to the cord management. So delayed cord clamping 30 to 60 seconds or until the cord pulsations stop. I don't do this on the regular. You guys don't have to be experts either. And when you're checking the cord for pulsating, don't squeeze, because now baby's not getting any of that and you essentially clamped the cord. I just hold onto it very gently, and when I start to feel it stop really pulsating, then I'm just putting my 2 clamps, the little plastic clamps that you have, and then cutting in the middle between those 2 clamps, and then leave those 2 clamps on until you get to the hospital. You do not have to put one of your clamps this close to the baby. It will not affect the belly button size that they have someday or anything like that. We actually like to have a lot of cord attached. It gives us a lot of wiggle room. If we have to insert like a UVC, we need to have some wiggle room. But if you clamp way down here, we don't have much wiggle room to kind of shave off to get to the vessels that we need, if we need to.
What's like the recommended?
We say at least 2 inches would be ideal, but like if mom is skin to skin and everyone's tucked in and baby's breathing and we're all happy, you do not need to disrupt that. You can clamp way down here and just cut right down there and just leave that cord. That will not hurt anything. We will trim it up later.
Does the cord normally pulsate in utero?
Yeah. Yep, constantly. We'll do it for it'll do it up to 3 minutes after. So yeah, just hold it, but let's say baby comes out and is not breathing at all, no respiratory effort, and you're trying to do all of those things, do not wait 60 seconds. If this is a really short cord and you can't get baby up to where you can start to maybe breathe for that baby or get that baby to breathe, or if she's hands and knees, right, and it's super awkward and like we can't get to your chest, whatever, baby's not breathing, you cut that cord immediately. Do not wait for the cord to stop pulsating. Clamp, cut. Have to clamp though, because if you cut, you will either bleed out your baby or mom will bleed out. So you have to clamp. That is the most important part for both sides. Okay? So yeah, the clamp immediately if resuscitation is needed away from the mother, or if you need to get a better position to assess why your baby's not breathing, just clamp. The moms will say, oh, I want delayed cord clamping. And then I'll just say, hey, I want that for you too, but I really want your baby to breathe. And they're usually like, oh, okay, yep, got it. Okay, any questions on the cord? No? Okay. Okay, so then that immediate, and this is like where I want to spend the most time, because this is, again, the most important part. Those 3 questions I ask, or everyone should ask immediately after that baby is born, is my baby term? Mom should usually know this, like, oh, it's way too early, or yeah, I'm due in a couple of weeks. That's all fine. The reason we ask if the baby is term and like due to come out anytime within like 3 weeks is because if a baby is preterm or less than 32 weeks, really small, we aren't going to be drying and stimulating like we would a term baby. And you will know that because when that baby comes out super tiny, their skin is not super developed. You won't want to rub it vigorously like you would a normal baby because you will like rub their skin off. So you don't have to know how many weeks she is because everyone says a little different. I'm 32 weeks or I'm 6 months or whatever. You just have to know, okay, are you term? Are you due anytime in the next 3 weeks? Or if they say, no, it's way too early. And then once that baby comes out and if it looks super tiny and super fragile, we're not gonna rub down that baby. We're actually just gonna put it in a little plastic bag. So the garbage bag you have in here for your placenta, you're gonna put it up to its little face in a bag, and it's gonna keep that radiant heat in, that wet, moist heat in the bag. Even if it's not, you don't have a bag, if you have any sort of plastic, if you have a drape or if you have any plastic, you're gonna just put it in that and keep that heat in. The preterm babies don't have that brown fat that normal babies have to regulate. So they can't thermal regulate with that warm blankets. And if you take away that moist heat, they're just gonna get colder and colder and colder no matter what. So, and then you're gonna cause them a lot of skin issues. But that's why you ask that term question. But again, most of the babies that are gonna come out are gonna be term. They're gonna be healthy. I'm not trying to scare you. That is not the goal. That's just why we ask that question. It's way too early. I'm really preterm or whatever it is. Like, okay, we're here for you. We've got you. After baby's born, I might put them in a plastic bag to keep them extra warm, and I want to keep their skin safe, right? And then, is the baby breathing or crying? You'll know that right away if you can hear it. Most babies who are delivered precipitously come out screaming. And it's the best sound in the world. We're not gonna try and stop that screaming. We're not gonna try and stop that crying. We're like, yay, keep crying. You're supposed to cry. This is the only time we want you to cry. Keep them crying. If they're crying, they're breathing. If they come out screaming and crying, you don't have to assess their respiratory rate. They're already doing it. You don't even have to assess their heart rate because if they are crying and they are breathing that much, their heart rate is fine, promise. Then you're just getting that baby skin to skin and you're reassuring mom, oh my gosh, look at your baby, it's so cute, you did so good, all the things. And then question 3, does the baby have good tone? So tone we can assess on this baby. And again, you'll know this right away after that baby's delivered just by looking at it. If it comes out and it is completely flaccid and it is not flexing any of its extremities and it is just completely flaccid, that tells me that baby needs help. So that would be one of those questions. Why that's important is that baby has no more reserves, it has no energy to give, so I'm gonna have to help that baby out. So if you have a baby that comes out crying and is like this and all scrunched up, and that's perfect. Keep that baby crying. But the low tone or no tone, it would be, if you can't tell if mom's holding it weird, but if you like took their arm and it just completely against, like no gravity fell to the, wherever you had it, that would tell me I have no tone. I'm gonna try and help further assess my baby. Even if any of these 3 questions are a no, the term, are they tone, or are they breathing? If any of those questions is a no, then you're gonna go to your initial setup or your initial steps. And that is that number 6. We're gonna warm, dry, stimulate, no matter what. Even if that baby looks like it's not doing anything, our first initial steps, no matter what, are always warm, dry, stimulate. So let's get that baby to a flat surface so you can assess them. We're still keeping them really warm and cuddled, and we are like vigorously drying and stimulating them. We're not holding them upside down and spanking their butt. You don't have to do that. But I am just drying and stimulating. I'm wiping my nose and my mouth clear of any secretions that I can see. I'm putting on my hat, and I'm making sure my baby's in a good sniffing position that like promotes good breathing. If you bring a baby up to skin, that's great, but they tend to like shrink down on themselves or in mom, right? If mom has a lot of breast tissue too, they'll like smother themselves in there. Like you just wanna make sure, hey, I'm gonna reposition baby so I can see its mouth and nose and promote good breathing, okay? And so it shows that on step number 4, like reposition your airway. So after you do those warm, dry, stimulate, reposition your airway, and you're still not getting good crying or breathing, Then is when we would maybe jump to doing this. But really, if you do all of those steps, oh, did I unplug it?
You're good.
Okay. If you do those steps really good, warm, dry, stimulate, reposition your airway, most all babies will cry. Just with that alone, you don't need to do anything else. But let's say, heaven forbid, it didn't work or those maneuvers weren't working, then you're gonna pop on your mask, just as you would an adult, over the mouth and nose. This one has a nice pop. It only will go to 35 millimeters of mercury pressure. So that's good. Anything above 35, if you're getting to your 40, if you had used this, anything above 35 can cause a pneumo. So if you happen to grab this, be very mindful of how much you're pushing in. And you only want to breathe until you get chest rise. So don't go above chest rise, or don't try to go above, or if you're super, right, just a high stress situation, you're gonna wanna try not to do that, right? Just about a half. Okay? Does anyone know the respiratory rate babies should breathe? What's that?
Breath every 1 to 2 seconds.
Yep. And so in about a minute, that's about 40 to 60. So you don't have to be completely perfect, but if you can try to get 40 to 60 breaths in a minute, or one every couple of seconds, that's perfect. So I've got my good baby in a good sniffing position, and I just make a good seal. Meanwhile, if you have the extra hands, someone is still warm or stimulating this baby to get it to cry. Okay, so just because that initial didn't work doesn't mean we just stop and move on to only this. We're continually trying to warm and dry and stimulate this baby. Okay? This also doesn't have to be done immediately. We've got about a minute to decide, and I know that doesn't sound like a long time, but it'll be the longest minute of your life while you're warming and drying and stimulating. And if at about a minute my baby still isn't breathing on its own, then I'm gonna start what we call PPV, or that positive pressure ventilation, just by putting on my mask, and then a breath, 2, 3, breath, 2, 3, breath, 2, 3. And you can see I'm getting chest rise, 2, 3, breath, 2, 3, breath, 2, 3. If I hadn't been getting good chest rise initially with my first 5 or so breaths, then I'm just gonna reassess. Is my mask in a good position? Am I in a good sniffing position? And then I'm gonna go right back to it. Breath, 2, 3, breath, 2, 3, breath, 2, 3. If I popped it on and it was kind of half off my face, or maybe this wasn't blown up enough, I would insert some air into my mask. I would give it 5 more breaths, and if someone's looking, nope, you don't have bilateral chest rise, I don't hear breath sounds, then I'm gonna take off my mask again, and I'm gonna do a suction. So have your bulb suction if you can, or if you can't find that, or if it rolled under your cot like they tend to, I'm gonna grab my blanket. I'm gonna either suction out or wipe away my saliva or secretions that are visible, and then I'm gonna open up my mouth. Some babies will like clamp down their mouth really hard, so I'm just gonna slip my little pinky in there and try and get them to open their mouth, and then pop my mask on with their mouth open. I'm gonna try again. Breath, 2, 3, breath, 2, 3. Whoever I'm working with, or if I'm looking and nope, I still don't see chest rise. If you're listening with your stethoscope, I don't hear any air movement, however you wanna say that. We're gonna try, and then we're gonna, if you increase your pressure if you can. If not, I might hop to do you guys, oh, I didn't ask that. Do you have an LMA or an iGel? Yeah. Then if that still wasn't working, then I'm thinking, okay, maybe we've got like a blockage below the vocal cords that I can't clear. Or I'm
I don't know if we have a
the size 1.
I don't know if we have a size 1 though. Yeah.
Yep, that's it. Perfect.
Yep.
Anyone is within anyone's scope of practice to insert an iGel, and they're super, super easy. So if I still wasn't getting with the interventions that I was doing, repositioning my mask, I gave a couple more breaths, I suctioned out or I wiped away secretions and I opened their mouth, I still wasn't getting any. I could look at increasing my pressure, but if you've got gloves on and it's slippery and slimy, do we know how that's probably not? So then I'm thinking, okay, now I think I need an alternate airway. At this point, we're about 2-ish minutes of life, and if baby hasn't taken a good adequate breath yet, now is when I'm gonna wanna really get in my alternative airway, and I won't open this, but you know it's activated by gel, and you just slip it in until you meet resistance, and then it might back out a little bit as it expands, but it'll nestle. This isn't a below the vocal cords intubation, so any secretions below their vocal cords are still gonna be there, but we're gonna help them out and give them a little bit more breath with a really good seal. So we might, and don't worry if that baby had meconium or blood, and if you push that into their lungs, they're gonna cause problems. You're not. We'll treat them with antibiotics later. We just need to get those lungs to start expanding. So eye gels are actually with neonatal resuscitation. It worked, they're actually really promoting these, even in the hospital setting, just as important or as effective as an ET tube. So you don't have to have an ET tube. As you had this is just really awesome. These really don't cause a lot of damage. So even if you jumped the gun and you forgot a couple steps and you were super worried that baby wasn't breathing and you slipped this in, it's really not gonna hurt. You just take it back out. If that baby starts crying around it or really get some good tone, you just take it out. Now again, I don't want you throwing this. I've never put one in a baby, only on simulation, because if you do good warm, dry stimulate, your baby should cry. But you could use this if you absolutely need to. If you thought, all else has failed and you want to try something, you could absolutely try this and you don't have to hesitate.
Should we even consider using oral airways?
No, I wouldn't.
Perfect.
No.
Great. Awesome.
No,
Yeah.
we don't use them in the hospital.
Okay.
For babies.
Yep.
I do want to the point, I know you had wanted me to do compressions, and I will happily do that. I just, again, want to start and just say that less than 4% of all babies born need cardiac compressions. Unless they have a true cardiac condition that was diagnosed in utero, those babies might need it more frequently. And if mom tells you, oh, it has, this certain heart condition and whatnot, maybe I'm thinking that, but really less than 4%. So, of the babies delivering out in the wild, that number would be even less, need compressions. But you cannot and don't start doing compressions until you have an alternative airway. So unless you have your eye gel in or you don't need to, don't start compressions unless you have an alternative airway.
Anything less than 60 beats.
Yep, until you have an alternative airway. Yep. And then after I have a full minute of my alternative airway in, and I've given that alternative airway a full 60 seconds. Again, will be the longest 60 seconds of your life, and you have chest rise, and it's a good airway, you don't start compressions even after 60 seconds, even if your heart rate's below 60. You give that alternative airway time, because most babies just need to breathe, and then their heart rate, boop, 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 will come back up. Can't start compressions on a baby who's not breathing, because you have nowhere that oxygen's traveling, right? If you're not breathing, you're not perfusing, because you don't have any O2. What are you perfusing? So do not start compressions unless you are breathing for that baby with an alternative airway. Okay. Back to maternal postpartum care number 7 then. So immediate after delivery, so monitor bleeding closely. There will be blood. It is a messy thing. There will be trickling of blood. Hemorrhaging is if literally the blood is pouring out of her. And it's super subjective as to what that is, but it's literally pouring out of her vagina and she's symptomatic. So if she starts to get super hypotensive, she starts to lose consciousness, you're just gonna treat her and assess her just like you would any other person. You roll up on a trauma and they're hemorrhaging or they're losing consciousness, treat her the exact same. We've got some tricks we can do to try and get that bleeding to stop, but you're gonna replace her volume, with some fluids. You're gonna support her respiratory, all the same things that you already do. One way, the reasons why most uteruses bleed is because they have no tone. So your uterus is just a giant muscle, and after you deliver, you want that uterus to be completely clamped down and hard to constrict all those tiny little exposed now vessels that the placenta ripped off and is now bleeding from all those littles. So we want that uterus to clamp down, to clamp all of those tiny little vessels. And if we don't get that and we're just loosey-goosey, none of those vessels are all just wide open, they're going to bleed. So a way that we can do that, this one doesn't have a uterus, but we can pretend, is you just support with one hand right at her pubic bone, and then the other hand, usually right at their belly button, you're just gonna push. I usually say try to find their spinal cord. You push down super hard and you kind of cup your hand around their uterus, and it'll feel like a grapefruit or like a softball. It should be really hard. You should feel a big hard lump, and if you don't feel that, you're just gonna keep massaging and massaging and massaging until you get that uterus to firm up. I know. They probably are not gonna like you. Yes. They aren't gonna like you, but again, if we're educating as to what we're doing while we're doing it, most women are super receptive to that. If I can explain, I'm massaging so that you stop bleeding. I really need your bleeding to stop, and I know this really hurts. Just try to breathe with me, but I have to keep massaging. They're gonna be pushing your hand. Yep, so until you feel it, it all just kind of feels like mush. And then once that uterus starts to firm up, it really does feel like a grapefruit right under their skin.
Do you just make them the same place, or you kind of creating a circle?
Nope, I start at their belly button, and then I just work my hands down until I start to feel it. And then once it's firmed up, I'm just continually massaging. Okay, so that's one trick you can do. You can also ask, question?
Does it get smaller as it firms?
It won't really start to shrink down into their pelvis until like a week or two out. So it'll always kind of just be up there for you. Yep. You won't feel it like going down into their pelvis. It'll just stay right there. You can also ask your mom last time that they've peed. And if she has a full bladder, there's not enough room down here. So if she has a full bladder, her uterus, it won't let her uterus clamp down. There's just not enough room for all of it. Her bladder will actually, so if mom's like, no, I haven't peed for a long time, or I don't know, I might have peed when I was, just say pee, literally just pee. Can you pee? Pee for me. If she can empty her bladder, that can be another way. Some of the nerves are like stunned after delivery, so they might not be able to pee. Do you guys have like a straight calf or anything like that? No, that's okay. That's all right, you don't have to. But if she can just pee, just say, just pee. We already got a lot of fluids down here, just pee. Yep. Yep, we'll get you cleaned up, just pee. And if that, then she might not have to, or maybe she just had pee, that might not be the reason, but it's one of those like easy things for me that it, like, hey, to stop your bleeding, if we can empty your bladder, that's something you can try. That fundal massage, like I had said, transport promptly. Again, if you already hadn't been in the way, like get going. Some women just need that extra Pitocin, or they might need some Methergin or other meds to just really start them to clamp. Like you had said that mom had a clotting factor. All the interventions in the world, if she started bleeding, those aren't gonna work. They might work for a little while, but if she has a true clotting, like you're not gonna get her to stop. She needs some platelets or FP or whatever to get her to clot. Also, when you're massaging, you will push out blood and clots. That's okay. Another reason moms can hemorrhage is if big blood clots are in her uterus. You actually want to get those out. Those are preventing her uterus from clamping down. So as you're massaging, if she's throwing out like golf ball, I've seen football size clots come out, keep massaging and you want them to get out of there. If they're in there, she won't be able to clamp down. So just massage. If she has a good river while you're massaging, but she's firm, just keep doing that. That's okay. You're not causing her to bleed more. You're actually helping her clear that and then stay nice and firm.
We're doing no matter what.
Yeah, I would. I would keep that uterus firm. Yep. You're not gonna hurt. I mean, it'll hurt and she won't like you, but just educate while you're doing it. Yep, hey, I really wanna assess your uterine tone. Unless her placenta hasn't been delivered, you don't need to do that. If her placenta is still attached, you don't need to be massaging. Her placenta has a half an hour to come out. So after the baby's born, you don't have to be pulling on that. You don't have to be getting that to come out in a certain time. Half an hour should be plenty of time. If it hasn't come out already on its own, some will just expel on their own. That's fine. If it does, then we're gonna start to do that massage. But other than that, you can just leave it in there and the doctor will deliver it. Yes, exactly. We'll deliver it at the hospital. Even after 30 minutes, it's still okay. Unless she starts like actively hemorrhaging, then we're gonna like get that out of there. But that's okay. Yeah, we won't call a postpartum hemorrhage until they've lost a liter of fluid. So if you can look at your whole liter bag, but also that's super hard to assess when it's all in a towel. Or like if you went to a house and she delivered in the bathtub and you show up and you're like, oh my God, there's blood everywhere. A drop of blood in water looks really bad. So that might not even be a lot of blood. Even though it looks like a bloodbath, that might actually be just a super normal amount that came out for a delivery. Just try, rather than to try to collect how much it is, she can lose like and still be conscious even with losing 2 liters. If she loses up to 3.5 to 4 liters, she's really at risk for dying. But odds are before she does that, we can hopefully get her somewhere that can get, and just keep pumping in fluids bags with her, keep her volume up. Another way to get mom to stop bleeding and to clamp down is if baby is crying and doing really good and breathing on its own, but now mom's the only one having the issue, try and ask if we can get baby to breastfeed if she is breastfeeding. That nipple stimulation releases oxytocin, natural oxytocin, so that will cause her to clamp down. So it'll cause her to contract and to cramp. It's like, hey, let's have baby feed. And if she can't feed, like say, hey, can we do some, sounds very weird, and I know you're not gonna love it, but can we just do some nipple stimulation? And then get your milk, then your body is thinking, oh my gosh, I had a baby. Now I need to start creating milk and I'm gonna release my lovey-dovey, I love my baby hormones, and get it to clamp down. Just another non-medication thing you can do to try to get bleeding to stop. You can say I wouldn't even have her push. Okay. I'd be like, okay, yeah, you might, and if she might feel the placenta like in her vagina, and it's very uncomfortable. You can like hold a little bit of like gentle traction on it, because you're clamped, right? So you got your clamp between your fingers. You can just like hold gentle traction. Also, if it's a super short cord and you had to clamp here, I would hold a little because I don't want it to suck back up in there. I've never seen that. But I would just like hold it a little bit. But again, I know you only have so many people, and if baby's needing resuscitation, maybe all hands are on baby. That's okay. There's a surgical way to remove that if we had to. They had to, not me. I'm not doing that. So I would just hold, and if she feels it in her vagina and it's really uncomfortable and she wants it out, just give it a little pull. She can push a little bit and then keep that. And then you might see after that a big rush of fluid and blood. That's okay. We're just gonna massage until she firms up. Or she might already be firm. It's just what was hidden behind that placenta and now just kind of came out after the plug came out. Hemorrhage, I always ask myself the 4 T's of like what could be causing my hemorrhage. So tone, and that's the one I'm assessing first. Trauma, if she has like a big laceration and you can see bright red active bleeding from like a really bad tear, then I would hold pressure. But if it's not trauma or any big tear, then I'm not like holding pressure internally. That's like a bimanual exam, and yes, you can put your fist and clamp the uterus down around your fist if you need to, but truly just do your continual fundal massage. So tone, trauma, my thrombin, or like my clotting factors, my platelets. What were my mom's platelets before she delivered? You're not gonna know any of that, but is it a clotting factor? And then the last T would be tissue. Is there any retained tissue? So if her placenta delivers and a segment is still attached or the placenta's not intact, which I'm not trained to fully diagnose if a placenta is intact, but you would see like a missing like blob. It's pretty obvious. Then it's retained, then her uterus is gonna want to bleed to get it to come off, but sometimes they need to go in and like scrape that off. So those are like my 4 T's. If I eliminate one at a time. It's not my tone, it's not my trauma. I know my platelets are good, it must be tissue. Obviously the signs of heavy bleeding or hemorrhage, heavy vaginal bleeding, boggy uterus, and then all of your signs of like becoming hemodynamically unstable. Your hypotension, your tachycardia, your loss of consciousness or altered mental status. Again, you're just supporting your patient as you would any other patient at that point. And then the high risk situations, act fast, that shoulder dystocia. So if that head gets delivered, okay, so the head comes out, I'll just use my hands. The head is out, and then mom's pushing or whatnot, and it literally is called the turtle sign, is if that when she pushes, the head comes out, and when she stops pushing, the head sinks right back. And when she pushes, it comes out a little bit, but then when she stops, it sinks right back. That's called a turtle sign, and that's a shoulder dystocia. A shoulder dystocia is a bone-on-bone problem. So we have to get that shoulder bone out of her pubic bone. So causing tissue trauma isn't gonna help a bone-on-bone problem. So that's when, if she had been on her back or let's say she was in a car in a weird position or laying on her back, that's when I'm gonna wanna try and flip her position. If she had been on your gurney on her back, I would lay her head completely flat, and then you take both legs and you get your knees to your ears. So you literally lift their legs as far as possibly back as they will let you to try and get that bone to release from her pubic bone. 9 times out of 10, that McRoberts maneuver, it's called, where you are cramming their leg back up, like to their ears, will release that bone, open her pelvis just enough. Tell her to push through while you have her legs like that. It's really hard to breathe when you're like that. So if she needs to take a break, you can move them back down. Tell her, take a really deep breath in, pull those legs back, and tell her to push. Yeah, it usually works pretty quickly. If that doesn't work right away, like you're in a true shoulder dystocia, you have 3 minutes. And if you don't get that baby out in 3 minutes, really like neurological problems start happening, but don't panic. Don't panic. Try your next thing. If that didn't work right away, then I'm gonna flip her on her hands and knees and try and get that bone to drop down out of her pelvis, or just shift it just enough. Let's not get too far into shoulder dystocia. Like I said, most babies who are coming out that fast are gonna come right out. You won't have most likely that issue. Okay? And then the breech presentation, like I said, hightail it to the hospital. Do not try to deliver a baby through a foot hanging out, a hand, 2 feet, a butt. If you can tell your mom to breathe through your contractions, just get them to the hospital. Like our OBs are like, literally get them to the hospital. Yeah. Do not try to deliver that baby. We need to go to C-section. Unless they're like, it's their 4th, 5th, 6th kid, they might try to deliver a breech. If the baby still has really good heart tones, they will try to deliver it breech. And then maternal seizure, so if mom starts seizing, of course, follow your seizure protocol that you have, turn, position, suction if you need to, support them, and then continue to know that if mom's not breathing, baby's not breathing. So you have to get mom back and breathing again, and get her through that seizure so that baby can breathe again.
Is she delivering through a seizure?
Yeah, but like, no, yes and no. Sure, the body is amazing and can do that, but more times than not, if they're that severely preeclamptic, eclamptic, you're just getting a C-section. And then severe hemorrhage, again, we said get to the hospital. So if you go and you see mom's cord hanging out of her vagina, and the head might be there too, if she's progressing fast, this is a medical emergency because now your baby's lifeline is completely clamped. If you see that, you're just gonna keep this nice and warm. I'm not clamping it, I'm not holding it. You're just keeping it as sterile as possible, but like damp and warm. And then really, truly, this is where you will get a little more hands-on, is you just wanna keep that baby's head off of the cord. Yep, however it would be, yeah, you're clean, yeah, just like keeping anything from compressing this cord. If this cord is compressed, that baby's not getting any blood flow. So I'm just I've only had to do it once where the cord came out, and then I just sat on the bed and I lifted the baby's head, the cord was under, until we got to the OR. And then, so you would ride in on the cot or the gurney with your patient. What's that?
You're committed at that point.
Yeah, you're not taking your hands out of that, like that is your only job. You're just holding it, and then you're just like notifying your team, hey, I still feel, my cord is still pulsating, right? My baby's perfusing then. You're just like, you don't have to, if you wanna call it a number, you can, but as long as your cord is pulsating, and you want it to be ticking along. Like a normal baby heart rate is above 100. Ideally like 120s, 140s, so like ticking along. So as long as it's doing that, even if it's not and it's less than 100, it's still okay. It's not ideal, but as long as that baby's not completely compressed, so I'm just, like my fingers, I'm just holding that baby's head off of that cord until I get to the hospital. And you're probably riding to the OR with them until you feel the surgeon above you pull that baby's head off your hand. That was weird. Okay.
Did she come in via ambulance in that situation?
No, she was an induction, she ruptured, cord slipped through.
Oh.
HIV positive, yay.
Oh, I bet you have.
And then it's stat, so there's like no precaution, you know, it's just like, oh God. Yeah, anyway, it was fine. Everything was great. So like even that, right? Like your son who had the cord and they had to be resuscitated and we're like, oh my gosh, it was so terrible. He's fine, right? Babies are so incredibly resilient, and you're not, even if you think like, oh my gosh, there's gonna be such a bad outcome, if you follow those initial steps and you do that, they can go through a lot. They have a lot of reserves, they are resilient. Just work on that warm, dry, stimulate, get them to breathe, they'll be okay. Even if they had a really traumatic delivery or something like that, it is crazy the things that we live through. To promote that really good air positioning, I would lay them on a flat surface if you can, and then until you get that breathing corrected. At a normal, it's breathing on its own. I think everyone should practice listening to the heart rate. Within the first minute of life, you should try and get a heart rate. And I want to know that number pretty quickly because it's going to tell me what I'm like if I need to do an intervention. So my baby's not crying or breathing, and I listen to a heart rate. I listen for 6 seconds, and whatever number I get, I multiply it by 10. So I'll count it out, I'll listen for 6 seconds, and if I hear 10 heartbeats, and I have 100, now I know I'm okay. My heart rate, I want it to be 100 or above. If I'm below 100 in that, the 6 seconds when I just did that quick math, then I'm just gonna warm, dry, stimulate, reposition my airway. I'm gonna listen again. If I'm still below 100, even below 60, or I have no heartbeat, I'm still doing my initial interventions. If I have no heartbeat, I'm not immediately jumping to chest compressions. Again, why? You're not gonna do anything until you have an airway. So I'm gonna then, if I hadn't grabbed my mask yet, I'm just grabbing my mask. And I'm gonna give some breaths. Breath 2, 3, breath 2, 3, breath 2, 3. If that didn't work, I'm gonna quickly look at my mask, reposition, make sure I have the right size. Breath 2, 3, breath 2, 3, breath 2, 3. If that's still not working, again, I'm gonna look, do I need to suction out? Can I see any big gobs that I can reach with my towel or my bulb suction? Right back to it. Breath 2, 3, breath 2, 3, breath 2, 3. If that's not working, I would increase my pressure. But if you can't figure that out or do that, then I'm just thinking, okay, do I need an alternative airway now? Breath 2, 3, breath 2, 3. I'm drying, I'm stimulating. Still don't have that. I'm gonna grab my eye gel, flip in my eye gel. Breath 2, 3, breath 2, 3, right? Breath 2, 3, you hook it up. Do you have CO2 detectors? No.
Yeah, we do have inline ones to use with the eye gel.
Okay, that's getting super fancy and you do not need to do that. But purple puke, yellow good, right? Now I know I'm exchanging CO2. But you do not. That would be like super fancy if you thought and remembered to do that. You don't have to do that. Purple puke, purple bad, yellow good, gold.
What
If you had an ET tube and you were intubated, it'd be like you were in the stomach. You intubated their stomach. That works for adults too. That's not just babies. All babies sound crackly. Like what we would call crackly for an adult, or like hoarse crackles, that is like baseline for baby because they're full of fluid. So they're always gonna sound gunky. They're always gonna sound crackly. They're like, that's just their baseline until they cry and scream. When the baby cries, it's truly CPAPing itself. And this pushing the fluid out of its air or lungs. If a baby comes out and cries and then transitions to more of like a grunty, it's truly like a little grunt. It's like, It's okay, it's breathing. It's just a form of labored breathing. And I don't like to hear it, but it would be okay until we got to the hospital. It's breathing. So I'm just gonna continue to dry and stimulate. I do not need to intubate if I hear that because I'm breathing. It's just my baby's talking to me and telling me that it's having labored breathing. So if I hear that grunting, do you have air, just air on or do you only have like oxygen tanks? Okay. Only have O2, that's okay. I would not just hook up oxygen 100% and free flow it into your mask for that, for grunting. Nope, I'm not worried about the SATs unless your SATs are hanging out at but again, you don't have a way to monitor SATs, so don't worry about that. Don't worry about that. Just if it's grunting, just continue to support and maintain your really good airway. And then dry and stimulate. And if you can get that baby to cry, it will try to CPAP itself more than a grunt too. If you grunt, you can feel yourself CPAPing yourself. You feel that. That's what it's trying to do. The baby's trying to CPAP itself to push that fluid out. The best way to push that fluid out is to get it to cry. So I will, sometimes to get it to cry, I'll rub right in their little pelvis and really just, they don't like that. It's kind of a sensitive spot. Sometimes I'll really stimulate the bottom of their feet. Hey, I'll scratch around a little, not hurt them and scratch them, but I'll get them to cry. If they're on mom's chest and its little feet are at the bottom, I'll just grab their little feet and I just not with my nails, and I just push on the bottom of their feet to get them to cry. And then I tell mom, sorry, I'm gonna try and make them cry. I really want them to cry right now. But I don't want a quiet baby right now. So if you can get them to cry, if you hear that grunting sound, just try to do that. Hey, we're just gonna keep them crying. They're just having some labored breathing. Another form of labored breathing for babies is if they start to do some nasal flaring. Again, mild nasal flaring is okay. Will help them when they get to the hospital. They're still breathing, so it's not a huge deal. Or if they start doing some intercostal retractions or some substernal or subclavicular substernal retractions, things like that, and are really using a lot of their accessory muscles to breathe. Again, my baby's just telling me it needs help. We will fix that at the hospital. That might be a low blood sugar problem that you weren't gonna treat anyway. So just keep it warm and get it to cry.
That's a grunt.
Oh, here's the grunt. And it really does sound just like that. And everyone was like, oh, your baby is making those cooing sounds. And I'm always oh God. The grandmas are the best. Oh, it's tough. I'm yeah, I'm gonna take it. I'm gonna look at it. I'm just gonna reposition the airway. But it is cute. They're breathing. Regardless, they're breathing. I am not worried, super, super worried about this baby. I will be the longer it continues to do that, but just get it to the hospital and we will fix that.
Almost sounds like two rubber surfaces.
Yeah, it's their lungs, right? Your pleural, and they're trying to pop open those now fluid-filled alveoli to replace them with air. So that's what they're just trying to create, that continuous positive pressure, right? CPAP, they're trying to create that. Okay, do we want to listen? Maybe?
Connected, so I wouldn't do it now because it keeps jumping on and off of the connection. So, but we're good now, so I would do it now.
This baby, if you listen right here, and most babies, if you listen like right kind of in the middle is where the best place, or upper left chest is where you're gonna hear a really good heart rate. Again, I wouldn't get really, if that baby is crying and screaming, hands off. Skin to skin, dry stimulate. You don't need to know heart rate in that moment because it's crying and screaming. I guarantee its heart rate is just fine. So you don't have to check vitals on a baby. I just need to know if it's breathing.
Right now. Probably come to the baby because my connection's a little.
Don't pass the baby.
If sometimes too, you'll hear if you want to know if you can't see chest rise if you're giving breaths, and you want to know if you're giving effective breaths, you can listen to see if you're moving air. Sometimes it is hard to hear with their heart right there too, so you really have to practice. Okay, in my heart rate, I hear that, and now I hear, yes, I hear you moving air. I hear you're giving breaths. You don't really check pulses on a baby like you do an adult. You don't check carotid, you don't check brachials, you don't check femoral. You listen. You don't check umbilical. Some people will listen or feel under the umbilical, because you could if you want to, but just listen.
What was the heart rate set on that?
Right now.
Does anyone, don't tell them. Does anyone want to try and guess?
That's faster than 100.
Count it out. Look at your clock for 6 seconds.
I heard 12.
It just stopped.
It just stopped. Did it jump off? Let's listen for 6.
120, 130.
Okay. Anybody else?
Is that good?
I counted 12.
That's close. Yeah. So if you listen and you hear, fine. I don't need to know a number. That's beautiful.
No.
If you listen and you hear,
Sometimes it turns off.
then I'm like, ah, crap. I need to breathe. You need to breathe. You're not breathing.
Oh, there it is. Okay, got it.
It's easy to occlude, so don't push hard. Just
Okay.
more or less rest your.
So they can go up to like 180 would even, that's a little outside of normal, but it's still okay. And like try not to get fixated on a number.
I'm getting it updated.
Don't treat your number, treat your patient or your baby. So if your baby's crying and is nice and pinking up, and if you happen to listen and it's, don't care. I don't care what the number is, that's a good baby. Like if you have a mom who is using, that can cause preterm labor. Like cocaine, heroin will cause her to deliver. And then they're already disassociated from the real world. And so she might just completely deliver that baby. Babies don't start withdrawing. It depends on the drug, but most babies don't start withdrawing until like 6 to 24 hours later. So there won't be anything that you need to do. More times than not, most of them are uppers, and so baby's just fine. They come out crying and like jittery, and then they start to withdraw, and that's when we start to have the problems, and we'll treat. But most babies who come out precip, unless they're super preterm, are okay, even though mom has all like substances on board. That's good. I've never given Narcan to a baby, but we could. Like if you got them to the field and mom was really high on something, I don't know, fentanyl or something really bad, then we could do Narcan if we had to.
Would that be a same full dose?
It's a way smaller dose. And we would give it through like a UVC, or we would put in an IV. But most of them they'll be okay until hours later, and they start to come down, then they're needing help. Usually know when they come in pretty high. But yeah, it can happen, but we'll do a drug screen if we have reasons to collect drug screen, and then that'll tell us right away. And then usually most moms, if you ask them, most of them will be super honest and like, yeah, I just used before I came in because I was in a lot of pain. And that's their coping, right? When they're in pain or they're in stress, they use. And so when they go in and start to have pain, then they'll like over medicate themselves. You guys want to practice giving it some breaths, making a good steal?
Will you go through that situation one more time?
Yeah.
How you're going to assess with, before everything you would do before starting compressions.
Yes. Okay, so we'll just say that our baby is born, was born right now, and I have it up wherever we have that baby and I'm assessing. Immediately, as soon as that baby's born, I'm drying and stimulate, hi baby, and I'm kind of like, even if we're like holding baby, I'm gonna like support so that I'm in a good breathing position. If mom's holding baby or I'm holding baby, like, do you see how like they don't wanna breathe? Like, I don't wanna breathe like that. So then I'm gonna like, hey, as I'm checking it out, I'm drying, I'm stimulating, I'm putting a hat on, I'm rubbing it down, and I'm keeping like a good breathing position. And if those interventions initially aren't, and I don't hear a cry, or I'm super flaccid and I have no tone, I'm gonna put it on a nice, like, smooth, hard surface. And then where it's not breathing or crying, I'm drying and stimulate, then I'm gonna pop on my mask. You're gonna pop on the mask.
That's after 1 minute, right? So.
Yeah, ish, within a minute. Within that first minute, I need to know if they're breathing or crying or doing anything. And so, yep, I'm gonna create a good seal, and I would actually tilt that head up a little bit more. Yep.
There it is.
Yep.
A little bit of rise, that's all.
And so I'm just doing breath, 2, 3, breath, 2, 3, breath, 2, 3. If he hadn't been getting chest rise, or if he loses chest rise, right, and I'm that second person, I'm either listening or I'm looking for chest rise, I could tell him that, you know, hey, my heart rate's coming up. Or I had started with a heart rate that sounded super slow, and then he gives a couple breaths, and I start to hear, hey, it's effective, and we're breathing for our baby. Our heart rate's coming up. Beautiful, perfect. And then that baby should start to turn around and start to have some more tone and start to cry. Beautiful. Then you can stop. And you can continue to dry, stimulate, and get baby to mom. If it doesn't, after he tried a couple breaths, then we are going to take that mask off again, and then we're gonna look in, do I need to suction, or do I need to open out that mouth with a bulb, or just your towel? The baby was clamped down. I'm just gonna take my gloved pinky, open that mouth, and pop that mask on, and then right back to it. Breath, 2, 3, breath, 2, 3. That one has it.
After wiping it down, then.
Yep, if that baby, after you wiped it, wants to kind of like clamp down, I'm just gonna open it up, yeah. And then with my mask, I'll kind of like keep it open. In that good position, and then breath, 2, 3.
So now the left side there.
Yep. Breath, 2, 3, breath, 2, 3. If that still hadn't worked, then you could futz with your pressure valve here. But if I'm starting to increase my pressure, I'm thinking, okay, the interventions that I normally would do are not working. I would get my eye gel out and ready. And he's still breathing, and I'm like, nope, yep, I don't see chest rise. Let's keep breathing for that baby. And I'm drying, I'm stimulating and wiping my foot. And then I still don't hear anything. Again, I'm not freaking out if I'm listening and my heart rate had been, but now because we're not breathing, now it's going, I'm not freaking out because I don't have an alternate airway yet. So I don't care about my heart rate. I do and I don't. So then I would, if I needed to, odds are you will not need to do this, but if you need to, you can slip in your eye gel, unhook your mask, pop your valve on, and then breath, 2, 3, breath, 2, 3. Takes a little while for it to like settle in the airway. And then breath, 2, 3, and then right back to it, continuing to dry and stimulate. With your eye gel, that should give you good breath sounds, unless you've got some massive clog, which we didn't talk about. If that baby had like a really thick meconium and the fluids that came out was super chunky, and you think that there is a clog below the vocal cords, you could suction. You guys do have the proper size French tubing for it. And so in your rig, you had the normal suction. So you would just hook this up to your suction tubing, flip your suction to be between 80 and 100 millimeters of mercury. This one's nice in that, I've not used this, but when you pop on your suction canister, it has a baby where you want it. I just couldn't figure out how to get it there, but you would still hook up your suction tubing to your canister, one blue side here, and then the white tip would go in the other blue side. And then you could do a deep suction, but again, like that, you should not have to do that. And then you would just measure You would measure from the nose to the ear to like mid-xiphoid process. You could. You're not gonna intubate a baby with this. And odds are you're not gonna go in their windpipe. You're just gonna go down into their stomach and clear any secretions. You could. Like, yes, there's always a chance you could go into their trachea, but like odds of doing a blind insert of a French cath with no stylet are just so incredibly small. Odds are you're just gonna go down into their trach, into their esophagus and suction out. You could try it. It's not, the odds are that you're gonna have to do theirs. Yeah, you're not, I would just continue to try and stimulate and breathe for your baby and push that meconium plug or whatever it might be down. That's fine. We'll treat that with antibiotics later. Okay? I don't break this. Okay, what else? Okay, did that, and then, where were we? We put in our eye gel. If you have their eye gel in and you are seeing bilateral chest rise, and you see that when you deliver a breath, you are giving a breath or you can auscultate and hear your breath sounds, give that eye gel a full minute before you jump to anything else. Like less than 4% of babies need chest compressions, and it's so traumatic to do it on a baby. But if you had to, I will show. You'll line up between their nipple lines, and you just place both thumbs right between their nipples, and you need to coordinate with the person breathing. So it's 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Yep, and you go about 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
You're not doing continuous ventilations if you got an eye gel in place?
Nope, just do like that. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. Just like that. I've only had to do compressions on a baby 2 times, and the first time I jumped because I'm a human being and I make mistakes. I didn't have an alternative airway. I just had a heart rate of 0 and I panicked. So I didn't need to do it. And then the second time it was a 23-weeker, and it was the last resort. But I don't think that baby had a heart rate before it was born. So it was just something to try. Yeah. Oh, do not clap. Thank you guys. Like, the work that you all do is so, so important. And I know it sounds scary, but delivering a baby is super cool. And if you get a chance to, I hope you do. And I hope it's this smooth. Yeah. Warm, dry, stimulate. Keep that mom safe. That's the only calm. You be calm. If you panic, everyone's panicked.